Today's lecture we will cover the respiratory system part 2. Today's goals: we will review respiratory pathology, we'll take an in-depth look at asthma, we'll look at some of the two chronic obstructive pulmonary disease categories, both chronic bronchitis and emphysema. We'll also discuss what a laryngospasm is and how to identify and manage that. And then we'll also look at some pre-surgical and pre-sedation considerations, specifically those that we look at regarding healthy patients, and then some with some of the respiratory pathology that we already discussed. First, we'll start off with some of the common respiratory problems. We'll start off with asthma, then we'll look at COPD, airway obstruction, and then laryngospasm. So when we think of asthma is obviously a respiratory disease that has a pretty strong chronic inflammatory component to it. It has these recurrent episodes where we see the triad of dyspnea, often see coughing and wheezing. And then we see this classic triad as far as the pathophysiology. We see bronchoconstriction, we see inflammation, and then an increase in mucus production. And you can see this in the diagram to the right. You can look at the normal bronchiole, and you can see that the airway lumen is nice and patent and wide open. And you can compare that to the asthmatic bronchiole or airway on the right-hand side, and you can see that the airway walls are much thicker, which results from the bronchoconstriction as well as the inflammation. And then you can see that now there's some visible mucus production that's also occluding the lumen of the airway. And all this really serves to dramatically reduce the size of the airway, and that is going to severely restrict the air from being able to flow in and out of the patient's lungs. Some of the common triggers for causing an asthmatic attack include allergens. We can see exercise or stress-induced asthma. Certainly the presence of an upper respiratory infection can predispose some patients to having asthmatic attacks perioperatively. We can also see the same thing with chemical inhalation, and certainly smoking is one of the strongest ones. One of the ways asthma can be classified is by extrinsic or allergic asthma. It's one of the more common or most common types of asthma, usually has a childhood onset, and we see some variability in the symptoms that kind of correlates with the change in seasons. With this type of asthma, we do see the presence of IgE-mediated inflammation, and we can see histamine that's primarily responsible for causing the symptoms of bronchoconstriction. Another type is the non-allergic or intrinsic asthma classification. This is more of the adult onset. We see certainly less seasonal variability with this classification than we did with the extrinsic component. And then with this, once again, the other big difference is that we see normal IgE levels here with the intrinsic component. Often this is triggered by environmental stresses or airborne pollutants. So that can be another triggering cause with intrinsic asthma. As far as the pulmonary changes that we see with asthmatic patients, certainly one of the most prevalent things we see are changes within the airway that all produce obstructive changes. And so these lead to the change in airway lumen size because of the mucus production, inflammation, and bronchoconstriction is going to make an dramatic increase in the airway resistance. So air simply cannot move as easily in and out of those airways because they're not so wide open and patent. And so that's going to lead to a difficulty and also in difficulty in expiration and inspiration. And what we tend to see is a wheeze upon expiration. One of the big differences when we compare asthma and COPD, though, is with asthma, we see that the airway obstruction or the airflow obstruction is partially reversible and episodic, so it kind of waxes and wanes. We get these episodes which are really bad, maybe, and then it kind of goes back to normal. With COPD, the obstruction tends to be more stagnant and more chronic, so it's kind of bad all the time. And then one of the ways that we can identify these differences, or in terms of quantifying the airway obstruction, is we can look at a decrease in their pulmonary function. And specifically we'll look at the FEV1, and that FEV1 we'll talk about in a little bit, but FEV1 is how much air in terms of quantity they can breathe out in 1 second. And so with asthmatic patients and COPD patients both, they're going to have a decrease in the FEV1. They're simply not going to be able to exhale as much air in 1 second as someone who has normal lungs. Looking at the treatment for an acute asthmatic attack, there's a variety of treatments that we can pick from. One of the first things we can do is certainly utilize supplemental oxygen. And then really the name of the game at that point is to get those airways open. And so we do that by administering a beta-2 agonist that's going to act on the smooth muscle in the lungs. And so albuterol is really the primary agent that we choose from there. One of the more common ways we administer albuterol is with a nebulizer. And you can see that the dosing here, it's about 2.5 milligrams that's dissolved in or diluted in normal saline, and the nebulizer makes a little puff or cloud that the patient can then inhale, and that helps promote the albuterol to get down into the patient's lungs, into the bronchi, to then be able to cause the bronchodilation. Secondary means or secondary measures would include things like steroids, so your methylprednisone or your prednisone. Either one of those can be given to help decrease inflammation, but because of the delayed onset of the steroids, it's not a primary or first line medication. And certainly for patients that are having extremely severe asthmatic attacks, one of the last medications we can use as kind of a last resort is to utilize epinephrine. Remember, the epinephrine, when we administer it, is a non-selective in terms of its direct acting actions on alpha receptors and beta receptors, so it's going to activate beta-2 receptors, and that's going to also lead to bronchodilation. So we can use epinephrine. One of the more common ways to give epinephrine for acute asthmatic attacks is to administer 0.3 milligrams of epinephrine subcutaneously. That would be like your EpiPen for an adult, or 0.15 milligrams, or the EpiPen Junior for pediatric patients. So just as a reminder, your sympathomimetic drugs that we use for acute asthmatic attack, this would include your epinephrine. Once again, it's a direct-acting alpha and beta adrenergic agonist. And the main drawback with using epinephrine is because it's non-selective with its beta-2 agonistic activity, is that we do get our cardiovascular effects. So we're not selecting out just beta-2. We're also going to get beta-1 that's going to increase the heart rate, as well as some alpha activity. We're going to get a vasoconstriction that's going to potentially increase the patient's blood pressure. Once again, the acute asthmatic attacks, the range there you can see is 0.15 or 0.2 to 0.5 milligrams. Once again, I think your EpiPen Junior, your EpiPen are extremely useful for these. Albuterol, once again, is another sympathomimetic drug. It is a selective beta-2 agonist, as I mentioned before, and so because it's able to act selectively on the beta-2 receptors, especially when we inhale them, we're going to get the subsequent activity. We're going to get things like bronchodilation. If we do get any sort of cardiovascular effects, we can see some vasodilation. And there are a few beta-2 receptors on the heart, so we can get some mild cardiac stimulation. And remember that in order for the albuterol to work effectively, it has to be able to get down into the lungs to effectively reach those raw beta-2 nerve endings. If it doesn't, it's not going to work. And so in cases where it's a really severe asthmatic attack and the patient's really not moving much air at all, you can give them all the albuterol in the world, but if it's just pooling in the back of the throat, it's not going to get down into the lungs, and it's not going to have an effect. As I mentioned, as far as secondary treatment, your corticosteroids are commonly given. These help to reduce inflammation, and often, especially the late inflammatory response or stage. The corticosteroids really help stabilize the cell membranes, and it helps reduce the further release of histamine, which is going to decrease inflammation there. And it really kind of helps restore the airway response to any sort of stimulation. It'll make your beta agonist work a little bit more effectively as well. The biggest drawback with your corticosteroids, as I mentioned before, is the onset of action. It's so delayed that in an emergency situation, it's essentially useless, because the onset really takes 4 to 6 hours. So it's quite some time before we really start to see those anti-inflammatory effects. Here's a nice diagram that kind of shows the current treatment protocol for managing asthma. And the thing to really take home here is that you can gain a lot of information just by looking at the medications the patient's on. It'll really give you information to let you further assess how severe the patient's asthma is. For example, if they're on a medium dose inhaled corticosteroid and a long-acting beta agonist, you know that they're pretty severe asthmatic patient. They're about step 4 in this protocol. So, that's a lot different than, let's say, somebody who just has their albuterol inhaler and really only takes that as needed. That would be someone more in the step 1 protocol. Often with asthma, I like to mention there are a variety of medications that patients are taking for preventive means, and the hope there is that they're going to take them to prevent an asthmatic attack. Some of the common medications that we can see patients on that are inhaled drugs include the corticosteroids, that's beclomethasone, otherwise known as Qvar, and then fluticasone, which is Flovent. We can also see the addition of long-acting beta-2 agonists. The one that's most common here is salmeterol or Ceravent. And then, the corticosteroids obviously are given to deal with inflammation, help reduce inflammation in the airway. The long-acting beta-2 agonists are there to cause bronchodilation, and they're long-acting, so we get, long duration of bronchodilation. And then we also have this third class of anticholinergics that are also commonly given. And these help to reduce mucus production. And so these would include like ipratropium or Atrovent, or tiotropium, which is Spiriva. Commonly, patients are on combined medications or combined inhaled drugs, and really what these are combinations of the different class that we just talked about. So we have Advair and Comavent are two of the more common ones. Advair is fluticasone and salmeterol, so we get our inhaled corticosteroid along with our long-acting beta-2 agonist all combined in one inhaled drug. Or we have Combivent, which is our salmeterol, a long-acting beta-2 agonist again, and an ipratropium, that's our anticholinergic. So we can combine these two together. Another class that's been growing in popularity is are the leukotriene inhibitors, and this is otherwise known as Singulair, and this is a monoleucast inhibitor. It's a relatively new agent, and monoleucast or leukotriene inhibitors, what they do is they function by reducing inflammation that are caused by leukotrienes. And so if you remember back to your cell membrane breakdown and metabolism, we've got two different branches, and one of them is the production of leukotrienes. Then leukotrienes by themselves can cause asthmatic attacks. And so the thought here is if we reduce the production of leukotrienes, then we're going to reduce the inflammation and hopefully help make the patient's asthma better. And they've been shown to really that they are pretty effective, and they do help decrease the need for additional beta agonists, so things like albuterol and salmeterol. They're really more for preventive measures. They're not at all used for asthmatic or acute asthmatic attacks, and that's once again because of the slow onset time that does take a while to take effect. But for many patients, many patients are extremely responsive to the use of monoleucast or Singulair. Next thing I want to talk about is as far as the preoperative evaluation. For a healthy patient, what are some of the things that I'll look at is in terms of preoperative workup. Is you certainly want to take your stethoscope and listen to the lung sounds, and one of the things we're looking for there is to make sure that the lung fields are clear and they're equal both sides. And then it's often a good idea if you've got a monitor around is go ahead and obtain a resting SpO2 or pulse oximeter reading just on room air. That gives you a lot of information just in terms of how healthy the patient's respiratory system is. And you can, for example, if you have a patient, you put the pulse ox on room air and they're at 94, 95%, then obviously you know that they've got some sort of intrinsic disease going on in terms of the respiratory system. And so that would be someone that's going to warrant further investigation. If you put it on and it's 100%, then that gives you at least a further insight that the patient's probably healthy, and as well as everything else panned out okay as far as the review of their medical history, then I'm probably not that worried about it. Certainly one of the things I also certainly want to spend a little bit of time on is inquiring whether or not they've had any recent coughs or colds. And really the difference that I'm trying to determine, if they say, yeah, I've had a cold, my next question is whether or not trying to figure out if it's just an upper respiratory infection or a lower respiratory infection. And the reason for that is because patients that have lower respiratory infections are extremely prone to having an increased risk of intraoperative asthmatic attacks. These signs of inflammation, studies have shown that the signs of inflammation from patients that have a lower respiratory infection tend to linger, and they tend to be around for up to 6 to 8 weeks. So that's, quite some time that they're still going to be prone to having a perioperative asthmatic attack. In terms of the difference between a lower and an upper respiratory infection, for an upper respiratory infection, it's really kind of a judgment call. If it's just a runny nose and they deny having any cough or productive cough or any fevers or anything like that, and it's just kind of seasonal allergies, then oftentimes, I'll tend to go ahead with the case. However, if they have any other symptoms or signs, if they've got a fever or if they just have malaise, they just generally don't look good, they look sick, or if they've had any nausea, vomiting, then certainly I want to wait. The appropriate time to wait is about 4 to 6 weeks, and that gives the body enough time to heal so that that risk of perioperative perioperative asthmatic attack is severely diminished. In terms of asthmatic patients, as far as the perioperative protocol, I'm going to spend a lot of time looking at their medical history. I want to certainly inquire as to whether or not, how often are there asthmatic attacks, what precipitates them, what makes them, do they respond well to the albuterol, how often do they use the albuterol, what medications do they take and are they taking them. Some other things are, have they ever been hospitalized or had to go to the ER? Have they ever been on chronic oral steroid therapy? These are signs that suggest that the patient's asthma is very severe. And if it's severe enough, maybe it's not a case that I want to do in the office. Maybe, it's a case that needs to be referred to the hospital. When we look at patients that are well controlled in terms of their asthma, most of the time they're just fine, and they will do just fine in terms of office-based anesthesia, sedation. They really don't have a significant perioperative risk, assuming that they're well controlled and they've been on their medications and they don't have any sort of lingering lower respiratory infection. Whether or not I use an albuterol inhaler is really kind of a judgment call in terms of using it prior to surgery. One of the things that I do recommend is I usually have the patient bring their albuterol inhaler with them, and then what I'll do before we get started is I'll just check to make sure, number one, that it's full, and then number two, that it's not expired and they actually have it. If they bring it in or if they fail to bring it in, do I go ahead? Well, most of the time I do, but it's just kind of a nice thing to have there in case they do need albuterol. You can give them theirs. Certainly if you listen to their lungs ahead of time and they've got a little hint of wheeziness, one of the things that you can certainly do is have them use their albuterol inhaler before you get started. Have them take several puffs, give it some time, like maybe 3 or 4 minutes, and then listen to their lungs again. And if the wheezing's gone away and they look like they're doing fine, then they're probably okay to go. As far as intraoperative concerns with asthmatic patients, certainly the biggest worry that we're kind of on the lookout for is for them having an acute asthmatic exacerbation during the surgery. This will manifest primarily as wheezing. We'll also see an increase in peak airway pressures. That's really not that, we don't see that easily unless it's an intubated case. And so the main thing that we see for an open airway case or a sedation case is we're going to see or hear wheezing. They'll also look like they're kind of struggling to breathe. We can certainly see a decrease in exhale tidal volumes, and that's what we see on the capnograph on the right-hand side. On part A, you can see that we see a nice, during the expiration phase, you see that the vertical rise is fairly straight up and then kind of horizontal plateau, and then down below on part B you can see that's during the asthmatic attack. You can see it looks much more like a shark fin, and that really shows us that that lack of in vertical rise and horizontal plateau and more of a shark fin appearance indicates that there's more of an obstructive pattern with how they're able to breathe out the exhaled CO2. Also, you can notice potentially, depending on how severe their restriction is, they may start to retain carbon dioxide, and so you can see that potentially their carbon dioxide levels or end-tidal CO2 number will start to increase. Certainly, if we see that, then we need to take the appropriate steps and potentially even cancel the case if we see it beforehand. In terms of intraoperative concerns and treatment for an acute asthmatic exacerbation, one of the first things we want to do is increase the FiO2, the oxygen, so that any air that they're breathing in has more oxygen to make sure that they maintain or stay well oxygenated. And then depending on whether, if it's a general anesthesia case, then one of the next things I want to do is go ahead and deepen the level of anesthesia. And that's because one of the triggers, one of the more common triggers of intraoperative asthmatic attacks for patients under general anesthesia is light anesthesia. That light anesthesia allows them to get stimulated, and then they can respond by having a bronchoconstriction. For moderate sedation, then I'm going to take a different route. I certainly want to start administering. I'm going to go ahead with my oxygen, but I want to also think about administering a beta-2 agonist, things like albuterol, maybe epinephrine if I have to. Moving on, we'll talk about COPD. So COPD by definition is a chronic irreversible obstruction of airflow from the lungs. So comparing it to asthma, remember asthma once again was episodic and is at least partially reversible. With this we have irreversible chronic changes. And so the two most common types of COPD that we'll talk about today are emphysema and chronic bronchitis. And in terms of etiologic factors, what tends to cause COPD more than anything else is being around smokers or smoking. Certainly we have some patients that are alpha-1 antitrypsin deficiency that can also be a pretty potent etiological factor. So we'll start with the chronic bronchitis patients. These are otherwise known as kind of the blue bloaters. They tend to be more sedentary, overweight. When in looking at them, they tend to be more cyanotic or blue. And oftentimes they're just kind of breathless. They're sitting there, kind of can't catch their breath. They're just kind of constantly tachypnic. In terms of the disease process, it kind of closely mimics asthma, and we still see that same kind of classic triad of inflammation, increased mucus production, and bronchoconstriction, except that unlike asthma, this tends to be more of a chronic, permanent kind of thing. By definition, COPD, they have to have excessive mucus production and a cough, and has to be for 3 months of the year for a minimum of 2 years. So that really defines the chronic component of chronic bronchitis. Once again, the physical findings that we tend to see with chronic bronchitis type COPD, we tend to see a normal total lung capacity. We tend to see that bronchial thickening, that increase in lumen or decrease in lumen size. We're going to see the increase in mucus production, and in fact, we'll actually see gland enlargement that leads to help cause that increase in mucus production. And then all this really produces both inspiratory and expiratory obstruction. And so certainly we can see a decrease in the lumen size, a narrowing of the airways, and we can see mucus plugging where some of the airways actually can get plugged up and not permit air to move. Some of the other sequelae that can arise or accompany chronic bronchitis, we can see certainly a whole host of recurrent pulmonary infections, and that really tends to be because they're just not able to clear the secretions as well. We can also see in severe cases pulmonary hypertension, and that can lead to right-sided heart failure. The other class we'll briefly talk about too is emphysema. These are more the pink puffers, and so they tend to be more barrel-chested. They often have or can have pretty significant weight loss, and they'll sit around and when they breathe, they have this kind of classic appearance of having to purse their lips. And really what they're doing there is they're creating PEEP or positive expiratory pressure to help increase and keep those airways open. And the problem with emphysema essentially is that we're not able to empty the air very well. Our alveoli have essentially, in terms of the pathophysiology of emphysema, one of the biggest factors there is smoking. We also can see an increase in inflammatory mediators, and really what we have is those inflammatory mediators start to destroy the alveolar architecture, specifically the septa of the alveolus. And so really what we have here is a loss of that kind of elastic recoil of the lungs. The lungs kind of naturally want to collapse on themselves to expel the air, and with emphysema we really kind of lose that elasticity. The airways start to kind of collapse because of the unsupported nature of them, and so what we tend to see are this kind of obstruction of air because of the collapse of the airways, and so that's one of the reasons that we start to get air trapping. Looking at emphysema, we have, in terms of the hallmark signs and symptoms, one of the biggest hallmarks that we have is a decrease in the FEV1. Once again, FEV1 is how much air they can breathe out in 1 second. And so you can see that based on the percentage, if they can expel up to 60 to 70% of normal predicted values, that's classified mild. 40 to 60% is moderate. But if they're unable to expel more than 40% of what's expected, they've got pretty severe COPD. The respiratory pattern in terms of how these patients look when they breathe, often they've got pretty significant dyspnea. Often they're really laboring to breathe. They've really got to work to breathe, to move air. And oftentimes they're really kind of hyperventilating. If you counted how many breaths per minute and compare that to a normal patient, they're certainly going to be breathing at a much quicker rate. Looking at the treatment for COPD, one of the mnemonics to remember that is COPDER, C-O-P-D-E-R. C stands for corticosteroids. So kind of like asthma, we're going to give corticosteroids for the inflammation. Certainly oxygen's fine. Skipping down to your bronchodilators, that's where the D stands for. That's your anticholinergics, your beta-2 agonists. The P stands for prevention. One of the best ways to help COPD patients in terms of long-term management is to get them to stop smoking. There's some other things too. They can have more experimental therapies like lung surgeries to reduce the lung volume. And then, believe it or not, one of the best ways to help COPD patients is incentive spirometry, which is more the rehabilitation component, where it kind of teaches them to get the lungs open, get the air moving. In terms of the pre-sedation evaluation or workup, once again, just like your asthma patients, we're going to spend a lot more time with these patients looking a little deeper into their respiratory system. We want to make sure we take a good medical history. Oftentimes, if I see COPD, I'm going to look for in the medication list their inhaled beta-2 agonists, whether or not they've been on oral parenteral steroids. And then certainly, are they actively wheezing? Do they look like they're... Some other things that you may obtain to help identify or quantify the severity of the patient's COPD. You may want to obtain a chest film or chest x-ray. We can think about possibly ordering some pulmonary function tests, or at least evaluating them if they've already been run. You may want to get an arterial blood gas. That'll help you identify patients that are retaining CO2 and are hypercapnic. But one of the best ways, as far as a quick and dirty, or at least a quick bedside pulmonary function test, is simply to have the patient hold their breath for 15 seconds. And if they can't do that, then it's pretty indicative that the patient's got some significant pulmonary problems going on. And, if you do that and they can't hold their breath, then, they're probably not teed up and ready to go to surgery. And so we may want to refer to their primary care physician or a pulmonologist for further evaluation and see if they can improve their lung function a little bit more. Some other things to consider with smokers: we want to make sure that they stop smoking at least 24 hours if at all possible. We certainly want to make sure that these patients are well hydrated. One of the things that the hydration does is it helps loosen up the secretions and clear the airways a little bit more. And once again with these patients, we can consider the use of aggressive incentive spirometry and deep breathing exercises. And once again, the goal there is to help open up the airways and get the air to move a little bit better so the patients can breathe a little bit easier. In terms of the benefits of smoking cessation, if they quit at least 12 to 24 hours prior to surgery, one of the biggest changes that we see is a decrease in the carboxyhemoglobin levels, and that's going to shift the oxyhemoglobin curve to the right, which will increase the availability of oxygen to the tissues. So that's going to basically make the body a little more well oxygenated. In terms of other benefits, we see a big benefit if the patient can quit at least 2 to 3 months before surgery. It takes about that length of time to see the ciliary and small airway function improve, and that can lead to certainly a reduction in any sort of the risk of potential pulmonary complications from occurring. With COPD patients, there are some intraoperative concerns. One of the biggest ones that we have is because of they can be hyperreactive to the respiratory depressant effects of narcotics or opioid agonists, so we want to be prudent in our dosing and monitor the patient's respiratory efforts to make sure we don't overdose and cause a respiratory failure situation. Certainly it's prudent to be observant of the types of medications that we use and maybe want to stay away from longer lasting opioid agonists, things like Dilaudid or morphine, because it can last for well beyond the period that we want to dose these drugs at. So these patients not only can be hyperresponsive to the depth, but also to the duration. They can have these drugs can last a little bit longer as far as the effects. We certainly want to make sure that we monitor for signs of oversedation. We're going to be on the lookout for CO2 narcosis, hypercapnia, make sure that they aren't obstructed or unresponsive. And remember that these patients can also be hyper responsive to volatile anesthetics as well. The volatile anesthetics, things like sevoflurane or isoflurane, your inhaled general anesthetics essentially, do have some bronchodilatory effects which can kind of help. With COPD patients, certainly one of the things that's classically taught is to avoid nitrous oxide, and the risk there, especially with emphysema patients, is that the weakened structure of the alveolus can get distended with the nitrous oxide, and that can lead to rupture and possible pneumothorax. So it's really kind of a risk-benefit thing in terms of how likely is this to occur. It's actually pretty rare. It's kind of more academic in nature, but nevertheless, I mean, if you don't absolutely have to have the nitrous oxide, it's probably better just to avoid it for these patients. In terms of ventilation, this is one of the biggest things we want to look at. Remember that COPD patients typically require big, slow breaths. So we're going to have big tidal volumes and very slow rates. We want to make sure that we give ample time for that air to empty out through the lungs. If we have them breathing at too quickly a rate, and once again, this is for patients that are intubated, what can happen is we can start to get a buildup or retention of air, and the patient's lungs can actually start to blow up, kind of like a balloon, and they can lead to really high pressures in the lungs. And once again, not only is that bad from an air retention standpoint, but that can also lead to a rupture of some of the bulla or the damaged septa alveolar structures. They can kind of pop. Moving on, we'll talk about obstruction, airway obstruction. So airway obstruction is one of the most common airway, in fact, it's probably the most common airway problem that can occur during sedation or general anesthesia with patients under sedation or general anesthesia. And this is one of the things that we're constantly on the lookout for. And really we want to get to the point where we can quickly recognize it and then initiate the appropriate response and manage it. In terms of recognizing airway obstruction, one of the things that we tend to see first is we notice a decrease or an absence of breath sounds. You simply don't hear the air moving in and out. You don't hear the patient breathing. And this is usually accompanied by their the respiratory drive still being intact. So they're not apneic from the sense of they're not trying to breathe. These patients are trying to breathe. It's just that their airways are closed off. And so you can see down below in the picture on the bottom right-hand side that with this sedated patient, their soft tissues have collapsed, their tongue has fallen back, and it essentially occludes the nasopharyngeal airway and also the oral pharynx. And so the air is not able to enter the trachea by either avenue. In terms of what causes airway obstruction, it can be a variety of different causes. It can be a foreign object. Most commonly in our field, it's going to be a tooth or a piece of gauze, something like that. Or it can be the soft tissues themselves. So very commonly it's the tongue as it kind of falls backwards because of the nature our patients are semi-reclined or reclined fully. As they become sedated, they lose the muscle tone that helps keep the airway patent, and so that tongue will fall backwards and obstruct the airway. We can also see the same kind of problem with patients with sleep apnea or oversedation, where everything just kind of collapses in and then the air stops moving. So in terms of soft tissue obstruction and management, one of the things that we do first, we can consider airway support. This would include simple maneuvers like a head tilt or a chin lift, or even pulling their tongue forward kind of out of their mouth to get that tongue off the posterior wall of the oral pharynx and reestablish patency of the airway. If that doesn't work, then the next thing we want to do is consider placing an airway device, and so this would include like a nasopharyngeal airway or an oropharyngeal airway. So in the picture down below, the nasopharyngeal airway is essentially a nasal trumpet or tube that goes from the nasal opening all the way through the nasal cavity back behind the tongue, and it really serves as nothing more than a conduit to allow air to pass from the external environment past the obstructed tongue component into the trachea or the lungs. The oral pharyngeal airway is the same way, except rather than going through the nose, it actually goes in through the mouth, and the goal there is to pull the tongue forward and allow air to pass behind it. Here you can see a variety of oral and nasal pharyngeal airways. One of the ways that I like to, you can see that the oral airways are sized according to the patient. One of the things I like to do is use a tongue blade. You can just stick a tongue blade in and push the patient's tongue down, and then just simply curve the oral pharyngeal airway in right behind the tongue. With the nasal pharyngeal airways, once again, that's sized based on the patient. And so you can just kind of measure for your patient to see what kind of size you think they need. And then it's usually lubricated. I like this lidocaine ointment because not only does it kind of grease up the nasopharyngeal airway and allow it to pass much easier, but the lidocaine actually serves to anesthetize the nasal mucosa, and so the patients tend to tolerate the airways a little bit better. Two other important notes are the nasopharyngeal airways are placed, they can be placed in semi-conscious or awake patients, whereas oral pharyngeal airways, awake patients are not going to tolerate placement of an oral pharyngeal airway. It's going to stimulate the gag reflex and they're going to throw up. Finally, we'll close by talking about laryngospasm and what that is. So laryngospasm, remember that when we have sedated patients, they're going to have impairment of their airway reflexes. And remember, your airway reflexes are there to essentially prevent material from accidentally entering into the trachea, and it kind of serves to protect the lungs. And so with sedated patients, these airway reflexes are not intact, they're impaired. And so when we add to that debris, and then we add in that the stimulation of the airway from the debris, the body's going to react, and one of the ways it can react is by closing off the vocal cords. They basically spasm shut. And depending on the severity at which they close, we can have a situation where they're partially open, we get some air moving, or we can get a situation where they're entirely closed, which is what we see on the right-hand side, where we get no air moving at all. And clearly, if we get no air moving from the lungs in and out from the external environment, that's obviously problematic. Remember that with this condition, the ventilatory or respiratory efforts are not impaired, so they're going to continue to try to breathe. It's just simply they cannot because the vocal cords are slammed shut. And so what this tends to produce is this kind of rocking boat motion in their chest, where you see the chest expand and the stomach kind of compress in, and then it reverses itself. The stomach comes out, the chest comes in, and so the chest and stomach kind of rock back and forth. In terms of management, the best thing we can do is prevent laryngospasm from occurring. We do that a variety of different ways. The first thing we do is make sure that we keep their airway clean and free of any sort of debris or fluids. And so we do that by, first of all, placing a throat pack or a curtain that prevents any sort of solid debris from going backwards and stimulating the vocal cords. You can see in the diagram to the left that's actually a dog, but what they're using there is a pharyngeal throat pack or a gauze pack, essentially, to prevent any sort of solid debris from going back into the vocal cords or the airway. The next thing we do is we need to make sure that we have suction readily available and keep the suction going so we can remove any sort of fluid, blood, saliva, secretions, irrigation, any of that stuff from getting any of that fluid from stimulating the vocal cords as well. So we're kind of constantly suctioning the airway. Your assistant's going to be doing that while you're working. And then we certainly want to make sure that we minimize any sort of stimulation, especially during stage 2. Remember that this is only going to include patients that are generally anesthetized because at that point, at stage 2, they're especially prone to laryngospasm. In terms of recognizing and then taking appropriate action with a laryngospasm, if we hear stridorous sounds, that's kind of wheezing coming from the upper airway, can be indicative of a laryngospasm, like a partial laryngospasm, where we still have a little bit of air moving. And in fact, if we hear no sounds at all, that's actually much worse because the vocal cords at that time are completely shut. We're getting no air movement. So that's especially bad. In terms of action, what we're going to do, first thing we're going to do is stop everything. We're going to promptly suction out the airway, clean the airway, make sure we remove any sort of gauze, any throat packs, any sort of fluid debris, any solid debris, of course. And then we're going to provide positive pressure ventilation. Most of the time with positive pressure ventilation, that will effectively manage the laryngospasm. It may take a little bit or several tries. But most of the time it does the trick. If it doesn't, though, we'll move on to other means. For those of you that are going to do general anesthesia, we'll talk about this first. If we have a situation with laryngospasm that's not breaking with positive pressure ventilation, then one of the next things we want to consider is administration of a short-acting muscle relaxant drug. So this would include succinylcholine. This is more of kind of a last resort. We're going to administer this if the patient's unstable or if the pulse ox is below 90% and you're unable to move any air whatsoever. If I have a situation like that, then I'm going to promptly administer succinylcholine. Succinylcholine takes about 30 seconds for an onset, so it's a very quick-acting drug, but you have to have it readily available. So succinylcholine is a depolarizing neuromuscular blocker, and so what that means essentially is that it will cause the muscles to fire, and so the patient will actually twitch or fasciculate. You'll actually see them kind of shake around a little bit. That's the fasciculations. It's a very quick-acting drug. If given intravenously, it acts, you'll see effect in about 30 to 60 seconds. You can also give it intramuscularly, but the onset's much slower. It's about 2 to 3 minutes. So certainly in an emergency situation, if we have access, we're going to give it intravenously. In terms of the duration of action of succinylcholine, it lasts about 4 to 6 minutes if given intravenously. Intramuscularly, it's a lot longer. It can last about 10 to 30 minutes. That's still, 30 minutes is pretty long. Succinylcholine is actually 2 acetylcholine molecules together, and so it's metabolized by acetylcholinesterase. And so patients with acetylcholinesterase deficiency can have a very profound or prolonged effect of any administered succinylcholine. It's also a known malignant hyperthermia trigger, so that's one more thing to be on the lookout for. In terms of succinylcholine dosing, you can see the adults on the left, the IV dosing. This is for if you're going to administer, a general anesthetic and then subsequently intubate the patient. You want ample time to be able to instrument the airway and put the endotracheal tube in. The dosing is about 1 to 1.5 milligrams per kilogram. You can see the pediatric dosing on the right. And then what we're talking about, though, for treatment of laryngospasm, you can see that the dose is much smaller. So an IV dose for a patient that is going to undergo general anesthesia, let's say that's a 70-kilo person, is going to get around maybe 100 milligrams or so. For laryngospasm, really what we're trying to do is administer a very small amount of succinylcholine, enough to get the vocal cords to relax so that we can reestablish airway patency and reestablish airflow. And so for that, we don't need this large, whopping IV dose. We just need a smaller dose intravenously, maybe somewhere along the lines of 20 to 40 milligrams. Often that's enough to just break the laryngospasm. Now, it's important to remember with succinylcholine that the patient will be paralyzed, but it does nothing for sedation. So you have to administer a sedative drug with it. So the other thing is, because they're going to be paralyzed, that means they're not going to be able to breathe on their own. So you have to ventilate them or breathe for them. And so we do this most frequently by use of a bag mask ventilation. A bag mask, we're going to squeeze the bag and force the air in. Also, we can consider intubation with either an LMA or an endotracheal tube at that point. For those of us that are not going to do general anesthesia and are focusing more on moderate sedation, we're probably not going to utilize succinylcholine. What we're going to do instead, and the main reason there is that we don't want to take away the ability of the patient to breathe. We probably won't have a lot of experience managing airways and ventilating patients. And so we need to think in kind of alternative means. And so what we're going to do essentially in this case is we're still going to suction the airway. We're still going to try to do positive pressure ventilation. We're going to consider placement of an airway adjunct like an oral airway or nasal pharyngeal airway. But one of the other things that we want to do is recognize that we have an issue, and then we're going to reach for our reversal drugs. So things like flumazenil and naloxone, and we're going to administer the reversal drugs early so that they have an effect, and hopefully they'll start to take an effect before the patient has any sort of appreciable hypoxia. So in terms of how this would go is you recognize that you think you've got a partial laryngospasm or a complete laryngospasm. You're going to suction the airway. You're going to go ahead and draw up your reversal drugs. You're going to administer those, and then you're going to apply your bag mask and try to break the laryngospasm while you're waiting on the reversal drugs to take effect. And remember that our goal here is to rapidly reverse the patient, because if a patient's awake and not sedated, they're not going to have a laryngospasm. So, and you or I just sitting here talking, if we have fluid or debris that goes back in our throat, we don't have a laryngospasm. What we do is we start to cough. Okay, so that's what we're trying to do, is we're trying to rapidly wake these patients up so that their laryngospasm will break. All right, thank you for listening. Please contact me via email or after class if you have any questions.